People Who Use Methamphetamine is also being co-hosted by UCHAPS, and we have Kenya Hutton here today, and so I'm going to turn it over to Kenya to be able to say a few opening words.
Hey, thank you, Magali, and thank you everyone for attending this important webinar. This is something we had thought about doing a while ago.
Kenya, we can't hear you. Have you unmuted yourself?
Yes, hello, do you hear me now? No, no. Hello, hello, hello.
We can hear you.
All right, well, Kenya,
they can hear you.
I'm going to, oh, you can hear him. Oh,
yeah. Okay. Kat and Ruth can hear Kenya.
Okay, all right, I just wanted to tell everyone thank you again. This is something we're really excited about doing together and partnering with NASDAQ. So again, thank you everybody. Thank you to all our wonderful presenters, and I hope you guys enjoy.
Great, thanks, Kenya. I caught the end of that. All right, so we're really excited that you all have joined us here today to talk about harm reduction with people who use methamphetamines. We are in the height of an opioid epidemic, and so there's been a lot of attention given to harm reduction with opiate use. And there also has been a lot of progress made, especially in terms of more like treatment methods that are conducive with harm reduction, such as opioid treatment therapies like buprenorphine. But with methamphetamine use, it's been very prevalent for a long time on the West Coast, including the Southwest and the Midwest. And it's also on the rise on the East Coast, especially as the U.S. continues to crack down on opioids. And this puts people who inject drugs in a position to try and avoid fentanyl. Methamphetamine use is particularly high among certain populations, such as men who have sex with men, especially who are in the party and play scene, as well as homeless individuals, and then increasingly women as well. So today we're going to hear from a handful of people who have experience working with people who use methamphetamines and providing harm reduction interventions to this population. So I'm going to go ahead and introduce the exciting and dynamic panelists that presenters that we have with us today. So Carlo O'Hilia received his PhD in nursing from the University of California, San Francisco in 2017. His research interest is on the intersection of substance use and HIV because of the deep-rooted structural and psychosocial factors that shape substance use among men who have sex with men. He is particularly interested in pre-exposure prophylaxis as a novel approach to reduce disease acquisition and its implementation so that delivery effectively reaches marginalized subgroups most at risk for HIV. His current work is examining biomarkers of stimulant use in an international cohort of men who have sex with men to see how stimulant use behavior affects PrEP adherence. We also are joined by Ruth Knatzer, who is the Syringe Access Director and Senior Health Educator with the Harm Reduction Action Center, which is Colorado's largest syringe service program. Ruth has been staffed with the HRAC since 2003. As a certified tester for HCV, Ruth is the Senior Health Educator for 4 health educator curriculums, conducting group and individual level interventions at the center. Also, Ruth is the Syringe Access Director and manages that program arm. Ruth has built great referral connections with other agencies and has developed a strong bond with the unique population that HRAC serves. Ruth has been working to both enrich the lives of injection drug users while also being part of the efforts for disease prevention through education, both on-site and off-site through community outreach. Ruth has partnered with the Empowerment Program Incorporated to offer emergency methadone services to injection drug users that are ready to quit using opiates. In December 2011, Ruth received the Josephine Roach Award from the City of Denver for providing excellent direct service to a marginalized community. Also from the Harm Reduction Action Center is Kat Humphreys, who is the Programs Director. In January of 2017, Kat joined the agency as the new Director of Programs and Data Evaluation. Kat spent several years in Denver doing harm reduction volunteer work and is a former HRAC volunteer and fundraiser. After spending nearly 4 years working in regulatory compliance, Kat was ready for a transition into direct service work. She brings her knowledge of policy, relationships with funders, and experience writing SOPs and other standard documents to the table to help the HRAC grow. As Programs Director, it is Kat's responsibility to manage interns, write reports, and analyze data for grants. conduct HIV and HCV testing for participants, assist the senior health educator in administering individual and group level interventions, and assist other HRAC staff in facilitating the syringe access program. As Director of Data Evaluations, it is her responsibility to track and analyze all syringe access data, evaluate program outcomes, and write monthly, quarterly, and year-end reports to submit to funders. As a note, all lines are going to be muted, and we are going to save all questions for the end. And also, please know that this webinar is being recorded and will be available on NASDAQ's website by the end of the month. So with that, I am going to turn it over to Carlo to give us an overview of methamphetamine use.
Thank you, Magali, and good afternoon, everybody, and thank you for having me. It's a pleasure to talk to folks who are doing great work to foster harm reduction in persons who use methamphetamine and other stimulants. And I apologize ahead of time. I'm feeling a little bit under the weather, so if you hear me sniffling, I apologize. So jumping right into it, my aim today is to provide really more of a general overview of methamphetamine use. Next slide, please. So our outline will be going over just a brief epidemiology of methamphetamine use in the US, its pharmacologic effects, negative health effects, and the different methods of delivery that folks use for methamphetamine. Next slide. So going into epidemiology, amphetamine-type stimulants, including methamphetamine, is the second leading substance of abuse globally. It's second only to marijuana. In the US, there's been a general decline in meth use over the last decade. This graph right here is from the 2013 National Survey on Drug Use and Health. The red line shows the number of new meth initiates, or really the number of people who used meth for the first time from 2000 to 2013. Although the trend is looking generally good in that the number of new initiates are dropping, we haven't really made that much headway in reducing the number of new meth initiates in the last several years. In fact, if you can, I can't really point to the screen, but if you're looking at the 2010 mark, beginning 2010, there was a slight uptick in the number of people who are age 12 or older who started using meth for the first time. And looking at the blue line, which is the average age at which folks reported first using meth, we're seeing that on average, folks start experimenting with meth at a fairly young age, ranging from 18 to 22 years old. And over the last decade, even more so than that, this really hasn't changed at all. So folks are starting, take-home message essentially is that folks are starting fairly young, and we're seeing a bit of an uptake in first-time meth users since 2010. Next slide. So this graph breaks down, I guess, the categories, if you will, of drug use in the U.S. You can see that in 2015, approximately 900,000 people aged 12 or older were current users of methamphetamine, representing about 0.3% of the total U.S. population who are aged 12 and older. Next slide. I wanted to include this graph because, as Magali mentioned, and as what we know from research, that sexual minorities, or folks who identify as either gay, lesbian, bisexual, or transgender, suffer a disproportionate burden of substance use in our society, unfortunately, and mental health problems as well. Oftentimes, these stem from multiple psychosocial and structural challenges. I wanted to show this graph from the 2015 NSDUH to highlight really the staggering disparities that we see in substance use faced by sexual minorities. In the survey, the prevalence of meth use among sexual minorities overall was 2.3% versus 0.6% among heterosexuals. When you specifically look at gay identified men who are 18 years or older, the prevalence of meth use was about 4.1%. Unfortunately, this survey didn't capture substance use behavior among transgender populations, who we know are some of the most disenfranchised in our society, and they are a key population for HIV risk reduction efforts. But some estimates place the prevalence of illicit drug use among transgender women somewhere around staggering 26%. Next slide. So now that we've talked a little bit about the epidemiology of meth, let's go into exactly what is meth, its pharmacologic and health effects. Next slide, please. So physically, the physical characteristics of meth is that it's usually a white, bitter tasting pill or powder. Crystal meth looks like glass fragments or shiny blue-white rocks. Next slide. Pharmacologically, methamphetamine is a potent stimulant of the central nervous system. In the brain, its primary action is to elevate levels of extracellular monoamine transmitters. These are things like dopamine, serotonin, or epinephrine. And chemically, amphetamines are similar in structure to dopamine, so that allows it to enter the presynaptic neurons and basically force dopamine molecules outside of their storage vesicles. They also block the reuptake and storage of dopamine and inhibit the destruction of dopamine. What this really all means is that methamphetamine use creates an excessively crazy elevated amounts of dopamine in the synaptic cleft, where it can then act on the brain's receptors. Studies have suggested that meth can increase levels of dopamine in the brain by as much as 2,600% more than normal. Individuals typically experience an intense rush that lasts about 5 to 30 minutes, and then this is then followed by a feeling of being high. Users also experience acute behavioral effects like feeling really alert, feeling awake, wide awake, burst of energy, feeling really good about themselves, suppression of appetite, and euphoria, or a feeling of just being super elated or very happy. Methamphetamine also affects the neurochemical mechanisms responsible for regulating heart rate, blood pressure, body temperature, among other things. So folks typically experience an elevated heart rate, high blood pressure, and other more systemic physiologic effects. At higher doses, meth has been associated with violent and aggressive behaviors and psychotic symptoms like hallucinations and delusions. Even after the initial rush subsides, the brain remains in this alert state and keeps the user's body on edge. And after the effects have worn off, the brain is essentially depleted of dopamine, and depression and fatigue are common withdrawal symptoms. Folks have described the effects of meth as this really intense high and euphoria, and the come down, or the withdrawal essentially, as being so horrible that they will do almost anything to avoid that feeling. So they chase that high. Next slide. So looking at the long-term effects of meth, repeated exposure to methamphetamine causes a whole host of negative health and behavioral effects. Primary among them is neurotoxicity. Neurotoxicity ultimately leads to changes in the structure and function of the brain. With repeated use, meth significantly reduces the binding of dopamine to dopamine transporters in a part of the brain that's important in memory and movement. So destruction of dopamine neurons can result in symptoms that sort of mirror Parkinson's disease. And in fact, studies suggest that folks that use meth, even past users, are at greater risk for Parkinson's disease. Methamphetamine-induced dopamine depletion is also known to stimulate locomotor activity, giving individuals that's sort of like that stereotypic twitch that we often think of with methamphetamine users. We also see neuropsychological impairment associated with poor impulse control, difficulty with sustained attention, lower speed for processing information, and then severe dental problems that, it's commonly called meth mouth, which really is just from a combination of drug-induced dry mouth, long periods of poor oral hygiene, clenching and grinding of teeth, which is typical of methamphetamine use, and then cravings for high-calorie and sugary drinks, and the acidity of the methamphetamine itself. Regular methamphetamine use is also associated with a high incidence of chronic psychotic symptoms. The most common signs of methamphetamine psychosis are hallucinations, especially auditory hallucinations, and delusions, particularly delusions of persecution. Studies suggest that psychotic symptoms spontaneously resolve in a little bit more than 50% of cases after they stop using meth. However, for some symptoms may be more persistent than that. And it's also been suggested that psychotic symptoms can be triggered even in former meth users during periods of acute stress. Methamphetamine is also known to cause changes to parts of the brain responsible for emotion, contributing to mood disturbances like depression, and then going into, obvious behavioral changes and risk associated with increased risk for HIV and hepatitis. As it relates to HIV and sex risk, meth is known to enhance sexual pleasure, delay orgasm, and facilitate prolonged sex. And because of these effects, meth is sometimes used as a sex drug in what's known as, you may have heard, chemsex or party and play. The drug is associated with high-risk sex behaviors in both heterosexual populations and in men who have sex with men. And this partly stems from the increased impulsiveness that folks feel, impaired decision-making, and hypersexuality. As it relates to hepatitis, it's thought that risk behaviors like needle sharing and sex while high play an important role in the transmission of hepatitis. About 15% of meth users overall are infected with hepatitis C, and about a staggering 44% of injection meth users were found to test positive for hepatitis C. Some of the neurobiological effects of chronic methamphetamine use appear to be partially reversible. Studies have shown that, like similar to psychosis. But in one study, researchers found that persons who had remained abstinent from methamphetamine for 2 years exhibited the same level of dopamine transporter activity as healthy controls. So this was associated with improved motor and memory performance. However, for some parts of the brain, they didn't see the same level of recovery, suggesting that the effects of methamphetamine are longer lasting for other parts of the brain. Next slide. This is really just a graphic that, if folks are curious, kind of summarizes like the systemic effects of methamphetamine. So this is something that you can feel free to look at a later time. Next slide. So jumping into modes of delivery. Next slide. So this table summarizes the various ways in which folks can use meth. I tried to be as extensive as I could, but I'm sure there's other creative ways out there that I haven't really included here, but this should give you a good sense of really the versatility of methamphetamine. I'm not going to go through all of these for the sake of time, but you'll hopefully have a copy of the slides for you to look at. My main take-home message here really for the slide is that different modalities of meth can entail different harm reduction approaches. So I would encourage tailoring your harm reduction conversations so that it's most relevant for the patient that's in front of you and how they use meth. And I'll end with that. Thank you again, and I'll pass the presentation back to our host.
Thank you so much, Carlo. That was really informative, and I think there's going to be lots of great things for folks to take away from those slides at another date. And so now I'm going to turn it over to Ruth and Kat for you all to go ahead and talk more about harm reduction for stimulant users.
Hi, thanks for coming out, everybody. Today, my name is Ruth Knatzer, and I work for the Harm Reduction Action Center, and I'm here with my coworker, Kat Humphreys. Say hi, Kat.
Hello, everyone.
Can you hear us?
Yes.
Okay. So I just wanted to introduce us and let you know that what we were trying to focus on, where we felt like a lot of our expertise could be useful to people today, was in how to manage some of the symptoms and outcomes of stimulant use and its long-term effects, or immediate. So we don't have a lot of slides, but go ahead, and I'm going to have Kat go through them real quick, and then we thought we'd just leave questions, because again, our expertise is really in the management. Next slide.
Awesome. So thanks for the introduction, Ruth. The first thing we kind of wanted to talk about today and speak to is what a stimulant overdose looks like and how to identify one. When you hear the word overdose frequently, it's associated, especially within harm reduction today, with opiate overdose. And since it's really not similar at all with what someone who is using stimulants is experiencing, we have a different term, and we call it overamping. So some of the things folks might experience when overamping are listed on this slide. So things such as fast pulses, shortness of breath. You're going to be hot either way. You might be sweaty, you might be dry, but overheating is really common. People are frequently confused and suffer from hallucinations, as mentioned earlier in this webinar. typical things like clenched jaw, you're shaking, flailing. I know we mentioned a tic earlier, but from what we typically see, it's a bit more exaggerated than that even. People might complain of chest pains, and they may or may not be mobile. They may be suffering from inability to control their limbs in such a way that does not allow them to walk or talk coherently with you.
And at this point, I'd like to point out that when we're typically talking to people about opiate overdose, there's sort of 3 levels. There's a moderate, a serious, and a severe. And something we like to share with people around stimulants and overdose is that there's no middle. There you go from moderate, which is some of the stuff Kat was mentioning earlier. As you move on down, as you see in this list on the slide, you get into very serious, where people are maybe clenching their chest and they are experiencing an inability to speak or move. At this point, because there's no real middle and there's also no reversal medicine that is widely available to the public, we always highly encourage people to call 911.
Next slide, please.
Next slide.
So again, this also speaks to something, what does this look like? More so than just observable. What is causing this? If you're in a community-based organization and someone walks in the door, a lot of this can oftentimes be attributed to sleep deprivation. One of the biggest pieces of advice that we have for folks who are experiencing a lot of trouble and using stimulants is finding a way to remove them from any type of environment that is overstimulating. And so sometimes that means you can find a place in the back room where they can sit and be in the dark to kind of reduce some of that stimulus for them. But it's gonna look like crashing, it's gonna look like a lot of anxiety, and almost always is accompanied by paranoia. If a person is conscious and you're sure it is not medical in nature, which we'll kind of get into in a moment, they may just need support and rest. And they may not be able to do it in that moment, but you can kind of guide them there through a number of de-escalation tactics.
And so what we're trying to help people get to is a place where they can sort of assess what's going on if you are working with people in real life who have either just very recently, upon coming into your center, used methamphetamine, or are also suffering the long-term effects of that sleep deprivation for being up for many, many days. Overamping can happen immediately after using, but also some of the similar effects of what overamping looks like can also be happening many days later because they've been awake and malnourished and dehydrated for so very, very long.
Next slide. All right, so some of the de-escalation tactics that we use in our agency involve staying calm, staying with the person and using their name. Something that's, it's just a grounding tactic. I know a lot of people are probably familiar with this from a lot of different harm reduction seminars, but it can really help to be the relaxing power in that room, right? Find a way to help that person relax, and that can be really, really difficult at times. So something that we recommend is getting them some liquid, some fluid, preferably water, something with electrolytes or other nutritional supplements. As Ruth mentioned, a lot of times dehydration, malnutrition, all of these things are adding just exponentially to what's going on when folks are overamping. So if we can get any of those nutrients back into them, it can help them get to a place where it's more manageable. As I mentioned earlier, overheating is a really big part of this as well. So you can place cool, wet clothes under someone's neck, head, armpits, anything that might cool them off is going to be helpful. If someone is getting aggressive and paranoid, if you can, try and suggest that they close their eyes. That might not be possible in the moment, though. You should definitely realize that. Give the person space and respect what they're going through. It's a pretty common theme to harm reduction, but something that I've seen really frequently, especially with stimulant overdose is that people tend to treat the person who's experiencing it like a child, and that's not helpful in the moment. Understanding that this person is still a complete adult and in charge of what they're doing and understands what's going on, but is just having a hard time functioning because the neurotransmitters keep firing in their brains. Treating them like children isn't going to help. So listen to what they're saying to you and really working with what the problems they're experiencing in the moment has been really powerful in us being able to help folks at least having a hard time on stimulants.
I usually validate their paranoia too, and then try to support it, not by saying that what I'm experiencing, what they're experiencing, or that it's even real, but that in that moment it is real for them. And so if we do isolate somebody, we try to allow that to accommodate for things like needing to have their back to a wall or being able to see the exits and or all of that. And again, like Kat was talking about, not to trivialize them. They are totally cognizant of what's happening, but they may be struggling, again, because of the misfiring in the brain, to communicate and to be able to physically execute small tasks. And so you can be supportive without being juvenilizing or trivializing them is really, really helpful. It requires a large amount of patience, but it will go really, really far to keep them from getting into a very frustrated and then aggressive, possibly acting out in even worse types of ways situation. Because often I found that acting out comes from the frustration of not being able to communicate properly in the way that they normally would want to because of the effects of the drugs. So just a little extra.
Another point we have on here is just encouraging the person not to take more substances. That can be tricky or complicated. A lot of times people aren't in the position to possibly take more substances when they're overamping, and sometimes they are. So until it's kind of become a more stable situation, we just encourage folks to not continue to redose. And then, or put anything else on board until you can make sure that the situation is under control. And then just a final point about de-escalation. Doctors can treat some agitation and paranoia with benzos. But if you're not comfortable, again, we encourage you to call 911. Next slide. And then just a final point about medical attention and when it should be sought, because this is a really serious subject and it can get out of hand pretty quickly, even if you think you can handle the whole thing. So if we have jerking or rigid limbs, somebody's rapidly escalating body temperature can indicate it might be a time to seek medical attention. If someone is unable to stay conscious, you need to call 911. Headache, sweating, agitation, again, as I mentioned earlier, those escalated problems like chest pains, clenched jaws, if someone begins foaming at the mouth, all of those symptoms indicate that you need to contact emergency services. Call 911, make sure you're keeping the person conscious. Again, make sure they're hydrated. You don't have to overhydrate them, but make sure they've had some fluids. And if their heart stops, then make sure to do chest compressions until paramedics arrive.
So I know in harm reduction, a lot of times we're serving people and also serving them in places where calling 911 is kind of not only always the greatest idea or the first thing that comes to our minds for all different kinds of reasons. But again, in this situation, I guess we just wanted to try and talk about how there is a time you can handle it and there's a time that you can't, and sort of what that the difference between the two looks like. And I would highly encourage people to try and handle it if you can, if they are not having those severe, extreme symptoms. And I think we're all smart enough to know when to call 911. But it can really switch on you rapidly too, which is the only reason you hear a couple of harm reductionists talking quite so much about calling for help. But it is also something that, again, with a lot of patients in the right space can be managed. And again, that's where our expertise comes from and what we thought would be the most valuable to share today.
Yeah, and I also just wanted to mention, you know, we've been having these conversations frequently, especially in Colorado among syringe access providers, but this is clearly not specific only to folks who are injecting. Overamping is easy to do no matter what your route of delivery is. However, it's come up really frequently that when people who use stimulants walk into the door of a harm reduction agency, the conversation stops. And so I did just want to say, if somebody walks in the door and they're having a hard time, the correct thing to do is not to send them back out the door. Finding a way to work with them can be very difficult, but so important to the work that we're doing. Specifically, just a piece of information from what we're seeing in Denver, our folks are using heroin and meth at equal rates, 50-50%. We have to be catering our harm reduction more towards this. So when someone comes in the door and they're having a hard time, whether that's overamping or just having taken more than they intended to or wanted to or feeling the effects of, one of the best things that we do is trying to find a space where they can sit down, be alone, and by alone, accompanied by one of our staff members, get them some water, put on some really calm music. Maybe that's classical music, maybe that's just something light, but it's very much like taking care of someone who's overheated. It's very much like just talking to somebody who needs to be heard. You do need to be paying full attention to this person. But it's pretty easy to mitigate some of those bigger problems. And it's really easy to keep folks off of the street while they're experiencing that and not sending them back outside. Any way that you can kind of shelter people and allow them to get their bearings again is going to be hugely beneficial to them, even if it's for a few hours that you can provide some sort of refuge for them. And we also had an infographic. I'm not sure if that made it into the slide deck or not. Oh, Yay! It did. Awesome. Cool. So I made this really basic infographic. This is we are an agency who works specifically with people who inject drugs. So this is some of the harm reduction is catered more towards people who inject, but a lot of this is universal. So I just wanted to share that and can share this image with anybody else who needs it afterwards. But it's just a quick guide for harm reduction service providers who are working with folks who are using methamphetamine and other stimulants. There's a really basic breakdown of understanding the brain chemistry of how stimulants alter neurotransmitters, and just understanding the large amount of stimulus that is going on in a person's brain when they're experiencing this overamping. I just put a quick few little bubbles in there about basic harm reduction tactics. I think we've probably touched on all of them at this point. People who are injecting stimulants such as cocaine may need more injection materials. They may need more syringes. We need to make sure that people who are using stimulants that need to inject more frequently are getting those supplies. We're not just having opiate catered syringe access. The second point just says if someone's having a hard time on stimulants, remove as much stimulus as possible. As we mentioned, a cool down room, keeping an eye on someone, making sure that it's a relaxed environment is very helpful. Number 3, providing water and nutritional drinks with dietary supplements can help. We've seen anything from Ensure, Boost, there's that emergencies help. Gatorade. Yeah. Gatorade, Soylent, any of those nutritional supplements can be really helpful to get people back to where they need to be so that they can stop having all the negative experiences associated with overamping. And then, yeah, the 4th is providing a cool down space. So, and then there's a final review at the bottom that kind of goes back over all that information, so I won't bore you with that, but this is just a really basic guide for service providers who haven't had a whole lot of experience with people who are using stimulants.
Like Kat mentioned, it was something that we sort of threw together after speaking to some other syringe access providers in Colorado who, as she said, they really don't know what to say to or how to provide harm reduction services to people who use stimulants, but that because we're seeing so many more people, and again in our center at an equal 50-50 rate, stimulant using and more often polysubstance use where they're using both opiates and stimulants, that we felt like it was really important that even if we couldn't give them much, we needed to give them something. And that we keep all substances and all substance users in mind when creating our space, getting our services tailored, and so on and so forth. So hopefully that was useful to you guys. That's all we have.
Great, thank you so much, Kat and Ruth. That was incredibly useful. I really love this infographic. And so now we're going to open it up to questions to both of our presenters or either of the agencies that are co-hosting this. So you'll see a chat box at the top of, or it says Q&A actually at the top of your screen. And so if you would please type in there, and please be sure to address it to who it is you'd like to answer it. And we can go ahead and help you pop that out to a presenter. All right, so this looks like it is from Joe Caldwell. Hi, Joe. I'm curious if there are any current national or state cascades on stimulant administration routes. Do we have a sense that folks are transitioning to injecting meth versus smoking or snorting, etc., at similar rates as people who are transitioning from smoking or snorting heroin to injecting? So it sounds like that is to anyone who wants to take it.
Hi, this is Ruth. As I sort of mentioned earlier, here at the Harm Reduction Action Center, we're sort of it's anecdotal at this point, so I don't know if anybody's actually looking at that in any kind of scientific way. But anymore, what we see is an increase in people using meth who weren't using meth or other stimulants before, and that it's more and more frequently in the picture and people who were before maybe monosubstance users, like I said, or polysubstance users. So again, I can anecdotally tell you we're seeing a rise, and also people who are still maybe injecting opiates but smoking and snorting stimulants, and then maybe not finding that they need both and beginning to then start to also inject stimulants.
Just to add to that, I guess I would piggyback on that and say that.
I'm sorry, Carlos, we're having a hard time hearing you.
Can you hear me now? Can you hear me now?
Yes.
Oh, okay. And just to piggyback onto that, I think really, not that I'm aware of that there's any solid data out there. I think the issue too is that, as many of you already know, this is a hard group for us to reach in terms of research-wise, trying to get information and all the legal aspects of reporting, illicit drug use. So that becomes a little bit more difficult. Unfortunately, not that I'm aware of there's data out there for that.
Thank you. And the next question comes from Chantal Prado, who asks if there is anything we can do to help a person with the meth depression that comes after.
I guess I'll take that. In terms of depression, a lot of the things that's coming out of that I've data-wise is that for some folks, the methamphetamine-induced or amphetamine-induced depression that comes after is largely antidepressant resistant. I mean, there was some guidelines I think that came out from Pharmacology Society or something like that that said a certain kind of antidepressant might be helpful. However, the data to support it is not as strong. So I think in terms of going through the withdrawal, there's not much. I think that there's not much solid data to support one medication versus another to support alleviating the depression.
So this is a time usually that in our conversations we start to talk about how there is not any recognized medical assisted treatment for stimulant users, and that there really should be. And as harm reductionists, that's a conversation that we are trying to have and want to have with as many medical providers, people who have prescription pads at their disposal as possible, because it is rather severe, right? It can be debilitating, the anxiety and depression that a person experiences after cessation of stimulant use. But and in cases where we've had individuals be able to access some sort of replacement therapy, I've seen great success with it. And it's just so not standardized, not really, I think even maybe it's probably frowned upon in certain medical realms. And I feel like it's our responsibility to continue to push that conversation and to talk about what that could look like. Because again, the small, handful of individuals I know who have been lucky enough to receive that kind of care, it really works. Like we know replacement therapy really works for opiate users. Oh, and somebody asked us if we're hearing our clients report fentanyl adulteration in their supply of methamphetamine. I hope that's what Sheila was asking. So yes, we have heard that. I don't really know what's going on with that. I think maybe sometimes people are just experiencing an inability to get high in the same way that they were before, and are thinking that maybe somebody's cutting their drugs with a downer because they can't get the same euphoric effect. I have no way to test those drugs, so we don't really have any proof of that, but I have heard our participants talk in that way, yeah.
We haven't been seeing any deaths or any information from the coroner's office that would indicate that there's fentanyl within the methamphetamine supply.
Yeah, it's all street rumor at this point.
Yeah.
Thanks. And it looks like we have a couple questions now that are asking you all to discuss safer smoking kits and harm reduction supplies, especially if there are any harm reduction supplies or interventions that are unique to methamphetamine use or stimulant use.
Yeah, so we now carry both safer smoking and safer snorting kits. In our safer smoking kits, we provide several items that have a lot to do with oral hygiene, which means keeping your mouth moist and not dry. So gum, candy. There is Chore Boy, so that is used as a filter in a stem if you're smoking crack. There's a push stick so that you're not handling your drug too much with dirty hands. We also provide snorting tools in case there's with our smoking kits. So there's a straw in there in case you have somebody who also wants to snort with you. And then there's what is actually a rubber spark plug cover. So we've repurposed that item as harm reductionists a long time ago. That way you don't have to put your mouth on the end of somebody else's pipe or stem, because often what's happening is you're burning your mouth and your lips, and you'll get kind of this chronic split lip situation where it hasn't been studied properly that I know of in any really good way, but logic says there could be some blood-to-blood contact from that, right? If I have that big split open lip and I hit the pipe and you have that same big open split in your lip, we could have a blood-to-blood contact. There's also, we keep sexual health in mind, like Carlos was talking about, so there's condoms and lube in there. And then with our safer snorting kits, they have multicolored straws, so if you're in a group, people can keep stuff straight. Mine is green, yours is blue, right? Something to take the drugs out of the baggie or whatever they're in and put them down on the surface so you're not touching them with your hands. A plastic razor blade so you can mix it up, as Carlos's slide said, to really crush it well, but without having to be at risk of cutting yourself. And then an actual clean surface. So it just literally looks like a blank credit card, but it's better than snorting, to snort off of that than off of the back of a toilet or other not so clean things.
And just one question coming from the NASDAQ side as a follow-up is if you all could talk about some of the advocacy around, or maybe even some of the problems around stimulant use paraphernalia, and especially with smoking and snorting kits, and what advocacy can or has looked like to be able to just create more access for folks and less fear of arrest?
Well, so the problem with that is that a lot of the same advocacy that's been done around syringe access needs to be done and has not been done, at least in Colorado, around the paraphernalia and other accoutrements that come with smoking, snorting, eating, booty bumping, all that other kinds of things. So we are unable to create a lot of protection at this time without just really trying to educate people. The safer snorting kits that we give out, honestly, would probably give people way more trouble than our smoking kits. A lot of the stuff in the smoking kit can be fairly benign outside of maybe the chore boy, could be passed off as and isn't listed under the law right now as paraphernalia, but it's usually going to have some sort of glass bubble or stem with it. That is definitely illegal in Colorado. If you're walking around with a little spoon and a razor blade and straws, everybody knows what those are for. Not exactly sure. I believe the law is probably ambiguous. That's why, unfortunately, law enforcement has a catch-all, drug paraphernalia charge that people are often given, and it's a shame because we are not always able to advocate and legislate in the same ways around these other items. It's just a whole other scene, but it's definitely work that needs to be done, and something that we think about on a regular basis as harm reductionists. It's just a step forward that we have not been able to, for capacity reasons, at least locally here, tackle yet. So we always let people know. I think your best tool in that moment is transparency. Just let people know, like, hey, you're running around with this stuff, you are at risk for getting paraphernalia charges. So at least be honest, right?
In San Francisco, I have to say, I guess we're a little bit fortunate for being in San Francisco. I think law enforcement and the city government has been a little bit more liberal in terms of how they view needle exchange programs and paraphernalia. So I think they've been a little bit more tolerant about that. And I think this has been a talk for as far as I can remember, but it sounds like this is gaining a little bit more traction in terms of starting or piloting a safe injection sites where folks can come in, inject under the supervision of a nurse or a medical provider. That way, if there are any issues that come up, somebody can directly intervene, and providing safer environments for that. But I'm not sure if, I think there was also conversation going on, I think with folks in Rhode Island, but I'm not completely familiar with where that's gone.
Yeah, I'm sorry too. I also see that Craig asked us if we would recommend an exchange, have a safe space for users to come in over amping. And there's another one from Matt. So obviously, yeah, if you have the ability to do so, having any kind of recovery space, right? So if people know that they can use and then come to you and be able to be safe and be observed for the signs and symptoms of overdosing, or just being able to kind of get it together while they're extremely intoxicated on any kind of whatever they may have injected, is always suggested. I know that capacity looks different in different places, but absolutely, it is a lot to manage. I will let you know, with stimulant users, it can be very intense, and they're very needy. They need a lot of one-on-one attention usually. But I would always encourage someone to create that space if they can. And then Matt said, what are the risks of using both meth and heroin either at the same time or independently? I mean, sure, Carlos could answer this one just as well, but what you're doing is, if you're adding a downer and a stimulant together, you're complicating a not breathing issue that can be handled with naloxone, with either heart symptoms or brain symptoms like stroke stuff, right? So, and also the body just isn't wired to do that. You know, we're wired to go up. We have naturally occurring stimulants. We have wired to go down. We have naturally occurring depressants. There's nothing that naturally occurs in our brain that takes us both ways at once. And so I think it's just a lot for the body and the brain to kind of handle. You can get into a situation where it just quits on you. So you lose consciousness. You may experience very extreme things like a heart attack or a stroke. And then if you have an opiate on board, that could also mean you're not breathing. So it's super dangerous. Carlos, do you have anything you want to add?
No, I would agree. It's basically just your body not knowing whether to go up or down. I mean, when you think of physiologically, when you're taking a downer or an opiate, physiologically you create vasodilation and things slowing down. When you add a stimulant onto that, it's the exact opposite effect. And so I think what you said of like folks stroking out or just stopping breathing or just having a severe cardiac event are very likely possibilities. Just from the fact that your body's like, I don't know what to do.
Mm-hmm.
And I guess going back to Josh I saw a question that Josh Rice had put in twice, just answering regarding chemically induced schizophrenia due to prolonged amphetamine use. What's the likelihood of that condition being permanent? They're saying somewhere around 20-30% folks experience psychotic features up to 6 months, even past 6 months after abstinence. In terms of, they do say that over time these things kind of subside, but what they've noticed is that folks, that even past users who had stopped methamphetamine use years ago, acute stress incidents can trigger psychotic episodes, and then if you have a family history of psychosis that is greatly exaggerated, I think your risk becomes higher. And I think what they've seen is that folks that have had prolonged psychotic features are folks that have had a family history of psychosis.
And it looks like Megan Hayes asked, what medications have you heard of being used for meth substitution therapy? And I do want to take this time to just plug that NASDAQ put out a guide. It was actually for AIDS drug assistance programs, but it was a substance use medication guide. And it talks about dextroamphetamine, which is extended release Adderall, as well as modafinil, which is actually a narcolepsy drug, which both have had efficacy and are used in Australia and some parts of Europe as methamphetamine substitution therapies. So just wanted to plug that, but I'll turn it over to the panelists now too, or the presenters. Any others you all have heard of?
No, that's about it. The people I know
Yeah.
who are being treated, like I said, that's a handful of them in the 15 years I've been doing this work. It's almost always the extended release Adderall.
Same here.
Great, and that's available on NASDAQ's website. And then I think Drug Policy Alliance made something about a harm reduction guide for stimulants. It was years ago, but it talks about dextroamphetamine as well. So.
The reason to not overhydrate someone, I guess Zachary has multiple questions, FYI guys, but we can only see the first one on our screen. Oh, thank you, Kat. Looks like it's on our end, sorry. Well, because Carlos, you're the doctor in the room, but that's not, it could cause them to vomit. If you really got it at extreme levels, you can cause water intoxication. It's pretty difficult to do that from what I understand. Is that your same kind of understanding though, Carlos, in an extreme case?
Yeah, I think it's a little bit, but when you think of somebody that's super amped up and very overly stimulated, I think the main concern probably is think of it as folks who went on binges, and so they probably haven't eaten or drank anything in a long while, and so think of like somebody who's been deprived of that, and all of a sudden you're like, all of a sudden there's like a gush of water, so your stomach and your system just isn't able to tolerate that. So I think the main concern would be vomiting, and then when folks vomit, they've got poor motor control already, that can go into the lungs, and it just causes even more severe medical issues. So I think slow and steady is probably the best route.
Small sips, yep.
And that second question from Zachary is, it seems like there is a lot of controversy about 12-step approaches in the harm reduction field, programs like Crystal Meth Anonymous. What are your thoughts on the efficacy of 12-step approaches for patients who desire abstinence? Would you ever refer patients to 12-step programs? Why or why not?
So we do refer people to 12 steps all the time. Personally, I do that mostly because historically, they really are the only people who are always there all the time, 24 hours a day, 7 days a week, 365 days a year, available for free for some positive social interaction. Whether or not the actual 12 steps ends up working to create changes that allow people to sustain sobriety, I have some personal feelings about the efficacy of those, but I have a lot of respect for their continued open door policy of wanting to be positive and help people have healthy, positive social interactions. And I also know people who will tell you that they absolutely saved their life. And so I always say, try everything. Try every option there is, and maybe one will work for you. Everybody is so unique, and what their path to recovery looks like can be very, very different, but 12 steps cannot hurt you, so it's always worth a shot.
And I think just to kind of speak a little bit to your question of asking why there's controversy around it, especially in harm reduction. I think when we hear resistance to 12 steps, it's mostly because that's the only route to recovery, whatever that means and looks like to the person, that's ever discussed publicly. So I think when we hear any type of anybody going against 12-step, it's because they want more options to be on the table for people. If you look into it, 12-step recovery plan, 12-step in general isn't super effective. And it doesn't work for a lot of people, but it works for a lot of people. So it's just one of those things where sometimes people have tried it and it hasn't worked for them, and there are other methods that they want to get out there. The vast majority of people that I know that have found recovery have done it on an individual basis, and they have no reason to tell you that. They have no reason to out themselves as a former drug user because of the stigma and shame associated with everything in our society. So I think the controversy around 12 steps is that there are other options and people can find recovery in a lot of ways, and to force someone into that type of situation can be negative. But for a lot of people, choosing a 12-step program works for them. So I think it's just really important to know that there are a lot of different ways that people reach that point and find a less chaotic relationship with whatever drug that they're using, and that 12 steps is not the only way to do it.
It's really true.
I think just piggybacking onto that is just I think I view harm reduction as really this approach of meeting where the clients are at, where the patient is at. If that's their goal and that is how they see themselves as recovering, then sure. But if they see other approaches, there are definitely other ways and meeting them where they're at is the approach, basically the way to go, whatever that might be.
So thank you very much to everyone. I feel like this was a really robust and helpful question and answer period, and I'm sorry we weren't able to get through all of the questions. I do want to say that NASDAD and also Reframe Health and Justice Consulting, which is a technical assistance consulting collective led by current and former drug users and sex workers, are offering a 3-quarter-day long workshop on harm reduction with people who use methamphetamines. And so if folks are interested, please follow up with either NASDAD or Reframe Health and Justice Consulting on that. And then also the Drug Policy Alliance is hosting a 1-day conference on September 25th in downtown Los Angeles at the Japanese American National Museum that will focus on harm reduction and treatment interventions for stimulant use. The aim of this conference is to engage participants in conversation about stimulant use, including motivations for use, epidemiology of use, related risk, and strategies for mitigating these risks. That registration is free and available online. And with that, I know we're at the top of the hour, so I just really want to thank everyone for participating. I know this really was a very kind of, the 1 hour is not enough to really talk about this, but this was really helpful in terms of especially talking about what meth is and then how to manage some of the effects of meth for folks who are coming into public health programs and syringe access programs. So thank you very much to Carlo and Kat and Ruth. We really very much appreciate you, as we appreciate our partnership with UCHAPS. And with that, I hope everyone has a wonderful day.
Thanks.
Thank you for having us.